All right, Chapter 41, which is Environmental Emergencies. Chapter 41, well, we're going to cover kind of some catch-alls here of things that are traumatic injuries that occur really from our surroundings. So heat and cold related emergencies, elevation related injuries, submersion style injuries, as well as oddball things such as a lightning strike. As with all of our chapters, if you have not read or studied the chapters on your own, please do so. Simply watching or listening to the lecture is no replacement for studying and taking notes on your own. So, same education standard that the Advanced EMT applies fundamental knowledge to provide basic and selected advanced emergency care and transportation based on the assessment findings for an acutely injured patient. There is a multimedia video in this chapter on near drowning. We have numerous objectives to this chapter that are found on page 907 and 908. All right, environmental emergencies occur when the normal body processes are affected by an external condition. So when the body's cold, it attempts to conserve heat. When it's hot, it attempts to eliminate heat. And when those body mechanisms are no longer effective, it becomes an emergency. So we have to be aware of the various risk factors. We need to be able to protect ourselves and the patient as well, because not always when we respond to one of these incidents are we perfectly safe from whatever's happened. Say we're talking about an exposure. So if we've been outside for 3 hours searching for a patient that we now found is hypothermic, it's very possible we could become hypothermic. Or we're outside in a lightning storm for someone struck by lightning. Could we get struck? Certainly could. Couple of slides there regarding our case study. So our body maintains its normal temperature, core temperature, through thermoregulation. The body has a couple of mechanisms in place to either allow us to preserve heat or expend heat. So whether we're going to sweat, we're going to dilate our vessels and make the heat come to the surface. So hopefully the heat's been pulled away through the evaporation and sweating process. Or we can constrict our blood vessels, shunt the blood into the core of the body, and kind of let the outsides kind of freeze a little bit as kind of a protective layer that will hopefully keep just the periphery cold, but will keep hopefully the core warm. So in these extreme temperatures, that thermoregulation is overwhelmed. Sometimes it's something that we've done, whether we've taken a medication or a substance that alters our abilities to do that. Maybe we've impaired our own judgment, or maybe we're dehydrated. There's lots of potential contributing factors that can play a part. So the body temperature will increase or decrease, and that's going to lead to an illness. Additionally, with the hot conditions, hypovolemia certainly becomes a potential problem. Hypovolemia from excessive sweating or urination, decreased amounts of intake. We lose water, but not only when we lost water, we lost electrolytes. Remember, I've said all along that water's best friend is salt, and salt's best friend is water. So as we lose those salts, we lose water, and vice versa. And in cold conditions, we can have frostbite. Basically, we can have the reverse of a burn. It causes essentially the same sort of damage that a burn would, and other related conditions. We generally deal much better with cold conditions than we do with hot conditions. A cold extreme, we generally can bounce out of that in pretty good condition, but an extremely hot condition, we don't do so well. So, thermoregulation is the process in which our body regulates that core temp, and our core temp is the temperature of the blood in the internal organs. So we generally kind of get an idea of that when we take an external temp, whether it's temporal or tympanic, maybe it's oral or axillary or rectal. And we get a good guesstimation, but in reality, Usually it's just a bit warmer on the inside than it is what we get from the external sources. So body detects that core temperature through its different thermoreceptors and those sensory nerve endings that monitor that temperature within our body. The hypothalamus is the primary regulator of temperature. So the hypothalamus up in the brainstem, the midbrain, is the regulatory mechanism. The thermal gradient is the difference between our body and the environmental temperatures. So, on the day that I'm recording this lecture, it's all of about 20 degrees outside. So our thermal gradient on a 20-degree day, if we were to go outside, would be somewhere around, say, 78.6 degree thermal gradient. So the difference between our 98.6 degree body and our 20-degree environment outside. So when we're inside, we have our thermostat set at, say, room temperature, which is roughly 72 degrees, 67 to 72 degrees, somewhere in there. The thermal gradient is much less. So we take it from a 78.6 degree thermal gradient to now a 28.6 degree thermal gradient. So it's much closer. Our body doesn't have to work nearly as hard to keep us at 98.6 from the 70 as opposed to the 20. Thermogenesis and thermolysis, or thermolysis. Thermogenesis is the process of generating heat. Thermolysis or thermolysis, is a process of transferring heat from the body to the environment, or giving off heat. Losing heat, if you will. There's really 5 major mechanisms that we will transfer heat. So whether it's from us to it or it to us. So conduction, which is a heat transfer from the body to a cooler object. So it's heat transfer from a warmer object to a cooler object that is directly touching it. So conduction would be if we're sitting on a block of ice. Sit on a block of ice, you're going to transfer some of the heat to that cooler object, causing it to start to melt. Well, in turn, we also get colder because some of the cold is actually transferring to us as well. We may have convection, and this is when heated air transfers molecules. Heated transfer of air molecules passes across the skin due to the moving air current. So when it's very cold out, we have very cold air molecules passing over our skin, and it cools us down. Likewise, when it's very hot out, it transfers heat to us. Those very hot desert winds could transfer heat to us that way as well. Radiation is a heat transfer from the body without physical contact. That's when you're sitting next to the heat, and you kind of have your hand out, and it may not even be blowing, but you can feel the difference in the temperature. That's through radiation. That's the way we get heat transferred to us from the sun. Evaporation. So this is sweat vaporizing and dissipating from the skin, carrying the heat away, usually by the process of water turning to vapor. And then respiration is often forgotten about one, but respiration is when we lose heat through exhaling our warm air and then inhaling cold air. So additional factors that may affect this, we have some contributing factors, if you will. Things such as a patient's age, their health, any medications they're on, length of exposure, intensity of exposure, any socioeconomic factors. The patient's age, the very old and the very young do not have good thermoregulation mechanisms, so that puts them at a higher risk. So the pediatric patient hasn't really built up the mechanism, and the geriatric patients, theirs have started to decline. So patient's health, somebody who has problems with their circulation, they don't do a good job of dilating vessels, constricting vessels to accommodate various heat factors. Kidney disease, they may be dehydrated, they may have a lot of toxins in their body. People who are immobile, they don't create a lot of heat, so there's a variety of factors amongst those. Medications. Some medications alter our ability to change vessel size. Sometimes they affect our central nervous system, so diuretics may remove too much fluid. So various other medications, or drugs of abuse for that matter, can affect that. Length of exposure. The longer you're out in it, the more likely it is to affect you. Intensity. The larger the gradient. So if we're talking, we're 98.6 degrees Fahrenheit and we go out and it's negative 40 degrees out, it's very, very intense. It's not going to take long at all for that to start to affect us. But it's 98.6 degrees outside with no humidity. We're going to do pretty well there. The body doesn't hardly have to do anything. We may not be comfortable, but the body really doesn't have a whole lot of work to do if it's 98, 99 degrees outside to maintain the body temp. It's pretty simple. But the more work we do out in it, we actually raise our body heat. So therefore, it makes it more difficult for us. And socioeconomic factors. Some people on limited incomes, they may not. Well, number one, they could have the mega socioeconomic factor being homeless and having to live outside. That, of course, would be an issue. People on limited incomes could certainly have reasons why not to turn on their air conditioning or turn on their furnace. Malnutrition, they don't have enough food to be their raw fuel to create heat by shivering. And then let's not forget that sometimes we have people that maybe are bridging several of these when we're talking maybe an elderly patient that has some dementias, that's on numerous medications and lives on a very limited income. We're hitting multiple bullets here at the same time simply for the fact they maybe have no real control over this and it becomes a bigger problem much, much quicker. So here's an example of the chart that is used for heat index, and it's the temperature in Fahrenheit versus the relative humidity. So if we're talking that it's 80 degrees out with a 90% humidity, it's going to feel like it's 85 degrees out. Whereas if it's 90 degrees and 90% humidity, it's going to feel like it's 121 degrees outside. And if it's 110 degrees with 40% humidity, it feels like it's 135 degrees outside. So humidity plays a huge factor in this as well because it doesn't allow heat to readily go away. It kind of acts as an insulator, more or less, almost like we put a coat on. And it shows you in various colors here, some of the possible heat disorders you may come across. Some heat fatigue, and possibly heat stroke, heat cramps, heat exhaustion, sunstroke, and then heat stroke very likely with continued exposure. So a variety of things to kind of keep in mind and pay attention. We'll have these heat waves, and I know Chicago routinely has these heat waves in which people will be killed or die because of the excessive amounts of heat, and then of course the limited resources that they may have. The environment does not have to be extreme for a problem to occur. It could be 40, 50, 60 degrees outside. Somebody stays outside for long periods of time and they're not well equipped to deal with that, and they can become hypothermic. In fact, spring and fall, a lot of people actually become hypothermic, unknowingly become hypothermic because they think, oh, well, the weather's so nice out, I don't need to worry about extra layers and so on and so forth. And maybe they're drinking, or maybe something happens. They had a car crash, and go undiscovered for several hours. And even though it was 40, 50, 60 degrees outside, their body core temperature drops because their body wasn't operating at capacity. Patients with impaired thermal regulation, of course, run a much higher risk of this. And then during scene size up, look for those clues to nature of emergency and potential for hazards. You're going to know how hot or cold it is out. A lot of times we pay attention to that weather simply knowing that, hey, if I'm on call tonight, what am I going to need to wear? What do I need to make sure I have available? Should we get a call and I have to stand outside for 35 minutes cutting somebody out of a car? Temperatures of 90 degrees Fahrenheit or greater, plus the relative humidity of greater than 75%, are ideal for heat emergencies. So you can have multiple people suffering from heat emergencies. Okay, so you could call to a job site, maybe people out on the ball field, something along those lines. You can have many people getting sick. So you may need additional resources. So make sure you protect your own health. So maintain adequate fluid intake, eating appropriate foods as necessary, limit things such as caffeine and nicotine because those affect your abilities to thermoregulate. Allow some time to acclimatize. Limit your time of exposure. Dress appropriately. Dress in layers. Remember, when we're going to be transporting people in the back of our ambulance, if it's a cold emergency and we need to crank the heat up there because they're hypothermic, if all we wore was very warm gear and we have nothing on underneath it, we're going to get really hot really quick because we can't shed our coat real quick to let ourselves be a little more comfortable while we have the heat cranked up for our freezing patient. So of course, things we pay attention to is level of responsiveness. Their mental status often changes and changes fairly quickly. So airway can potentially become an issue. Circulation can be affected by the particularly in the heat patients because of the relative hypovolemia that they may have. It's actually not relative, it's a true hypovolemia because they've had excessive sweating. Maybe they've also had some vomiting. So ensure the adequacy of their airway, breathing, and circulation, and then address any immediate life threats. Some of them, they need to be cooled immediately. So get them removed from the extreme environment, including if their clothing is an issue. So this is more of a problem with the cold emergency patient, because if we have the patient that's in wet clothing, that water, that moisture, holds the cold in. It's harder to warm them up if they're wrapped in wet items. So this may mean getting them completely undressed and wrapped in dry blankets to help minimize the heat loss and maximize the heat gain for this patient. So, and in some cases, we're going to take measures to stabilize their body temp. We need to determine whether they are a critical or non-critical patient, do the appropriate secondary exam, whether it's a quick head to toe or we do the more detailed or the focused. We're going to obtain some baseline vital signs or history, do the head to toe or focused based off of their problem. Maybe it's a frostbite injury, in which we're talking about fingers and toes. Chances are pretty good if we're relatively comfortable with this being isolated frostbites. We don't need to do a super head to toe. We're going to use our appropriate monitoring devices as we can, understanding that some of them may actually not work very well for us. So if we're using things like pulse oximetry, cold fingers, cold toes usually means bad reading. Blood glucose monitoring, you may have shunted so much blood from the capillaries that it's going to be very difficult to get a good drop off of a capillary stick. So maybe you're going to have to get it when you start an IV. CO2 is usually not affected as long as they're breathing, of course. Cardiac monitoring can be a problem because they maybe have shivers that's going to disrupt the reading. Of course, we're going to obtain any additional information that we possibly can. How long were they out there? What sort of wind speeds were we talking? Temperatures, humidities. How long was it since somebody's reliably seen them? how long do we suspect they maybe went without food, water, medication, etc. And of course, our reassessment is on our standard 5 and 15 schedule. All right, heat camps, which is actually heat cramps. Heat cramps, this is the least severe of all the heat-related emergencies. Anyone who has been a football player or played probably a fall sport, more commonly fall sport than it is spring sport issue, has probably dealt with heat before, cross-country runners, potentially even track, but has dealt probably with heat cramps. And we see this all the time on football games where there's a player down, they come up kind of stumbling and hobbling, they get them over to the sideline and they're pushing on their legs. They got their legs up in the air and they're pushing them. And the biggest problem is that they are dehydrated and have probably lost their electrolytes as well. And so stretching the muscles out, returning the fluids and the electrolytes back into the athlete are critical. So these muscle groups are starting to cramp up from overexertion and dehydration. So the signs of heat cramps include muscle cramps, usually in the larger muscles of the body, so it's usually the quads and the abdominal muscles, potentially the arms, weakness, sometimes a little shakiness, and then they may also complain of a little lightheadedness or dizziness because it's affecting their whole body. It really is. They've lost the fluids, they've lost the electrolytes systematically, but it's the muscles that are being pushed to the test that are really in need of them the most at the moment, and that's why it's seen mostly there. So it's really a very simple treatment for this. Remove them from the environment, administer some oral electrolyte replacement fluids, and some gentle massage or stretching of those muscles usually helps. So something like a sports drink, if you're going to give them a sports drink, it's recommended that you actually dilute it. So do a 50-50 with water because most of those sports drinks have plenty of electrolytes in them, but can maybe be a little bit too concentrated. And so putting them at half strength, they actually gain more water in the process and get their electrolytes at a little bit to the more normal level. So they can hopefully hold on to them as opposed to just dumping them. Too much at once, the kidneys are going to say, whoa, we don't need all that, boom, and kicks some of that extra out. But if we do it gradually with more water, they're going to hold on to those electrolytes. Worst case scenario, we have changes in mental status, and we're going to have to end up transporting this person. IV normal saline or IV lactated ringers, either one, could be appropriate. We rarely, if ever, will get to that with just heat cramps. So if they're nauseated, be cautious with drinking because we don't want them to aspirate. Heat exhaustion, this is the moderate heat illness. They have inadequate perfusion. They're basically in a mild state of compensated shock. They have increased vasodilation in the peripheral circulation, but don't have enough fluids to fill it because they've sweated out, they've breathed it out, whatnot. Probably have had prolonged excessive sweating, and that's caused their blood to become quite concentrated, but lost the excess water that's usually found in there. So our signs of heat exhaustion. I have suffered from heat exhaustion a few times. It's not fun. It really is. You feel physically ill for a while. Typically their body temperature is greater than 100 Fahrenheit, or 37.8 centigrade. Typically will have cool and diaphoretic skin. Their body is still compensating to a degree for the heat, but they can't compensate for the loss of the volume. They'll be diaphoretic because they are still continuing to sweat. It's the heat compensation. Tachycardia, because their body's trying to pump a little faster. Weaker pulses, muscle cramps, weakness, headache, dizziness, anxiety, and an altered mental status, including the potential for loss of consciousness. So again, we're going to remove them from the hot environment, remove their heavy clothing. Don't allow them to become chilled because now we went too far. But We may do a little bit of misting. We may turn the fans on to help cause a little more evaporation, help cool their body. We will only administer fluids orally if they're not nauseated and they're alert. These people potentially have much greater risk for an alteration in mental status, so we've got to be very careful that we don't have any nausea and evaporation or aspiration. So IV fluids could potentially come into play here. Cooling the patient is not critical, but it helps. The main problem is they need the fluids replaced. So IVs, LR, or normal saline would be appropriate. Then we have heat stroke. Heat stroke is a life-threatening condition. This is an emergency. The body's thermoregulator said, screw it, we can't handle this, I'm done, I'm out. Core temperature is usually greater than 104 or 40 centigrade. The mortality rate ranges from 20 to 80% based off of the patient's overall condition to begin with. The core temperature continues to rise uncontrollably because the thermoregulators have just shut off. They said no more. So the brain does not do well in high temperatures, and so it starts destroying and burning off brain cells. We'll have two major types of heat stroke that we deal with. The classic heat stroke, which is typically the elderly or the very ill person who is unable to escape the hot environment. Or we may have exertional heat stroke, which is probably a little less common. That exertional heat stroke, those out working in the hotter environments, firefighters, this is definitely a concern because obviously working in a large scale working or structure fire, temperatures get very, very high. So it's something we'd be terribly concerned with. So the signs or symptoms of heat stroke include almost always an altered mental status. They will stop sweating, although the skin may still be a bit moist or wet. On exertional heat stroke, in most cases that stops very, very quickly. They will have hot, flushed skin as opposed to the cool, diaphoretic, pale almost skin that they may have. Now that can be the heat stroke with the cool, diaphoretic, pale skin. That can be disguised, with the sunburn. But the cool skin usually is, and diaphoretic skin is usually the kicker as opposed to the hot, flushed, dry skin of the heat stroke in most cases. Rapid and deep respirations that will proceed to become shallow and slow. Tachycardia that becomes bradycardic, hypotension, and possibility of seizures. So this is truly, we have gone beyond compensated and we're now headed down the decompensated route for shock here. So we must rapidly identify this and start treatment on this. So this is going to require us to rapidly cool this person, got to get them out of the hot environment, get all their clothing off of them, get them covered with a sheet. We usually are going to wet that down or we'll miss the skin. Crank up some air conditioning. We need to decrease their core temperature to 102 degrees Fahrenheit. We can put cold packs in the groin and in the armpits and on either side of the neck. This helps pick up some of the coolness in the blood vessels, which are real close to the surface of the skin. And so that's where those cold packs in those areas becomes very important. So, and do not cool them to the point in which shivering occurs. Shivering generates heat. So if they start to shiver, back off on some of our cooling measures. If their body starts to generate heat, it starts driving their temp back up. So we don't want to do that. That's what shivering is intended to do, is to create more heat within our body. So that is a point in which we're stop cooling measures. Definitely get a couple of IVs in them. Large bore would be good. Isotonic crystalloid solutions, so probably LR or normal saline. Fluid losses can exceed 1 to 1.5 liters. Follow our protocols. Usually, if we're talking hypotension, we're going to try to get that temperature back up there, get their fluid levels back up there where we have at least a permissive hypotension going on. Seizures are a possibility. So if you have a patient with suspected heat stroke, we probably need to be considering calling for paramedic assist. Then we have the other side of the coin, the cold-related emergencies. So we have general hypothermia, which our body core temperature has dropped below 95 degrees Fahrenheit. Severe hypothermia is a life-threatening condition with a mortality rate of greater than 80%. However, luckily, many people with, they may have proceeded into hypothermia, but if we get care to them in a relatively expedient time frame, we can usually have them bounce back without permanent deficit. So our body's thermal regulation has again failed us. Core temperature starts to fall very quickly. Cardiac output decreases. It leads to cardiac arrest and can lead to death. Now the body, we still have the innate ability to activate our mammalian diving reflex, which occurs when we get cold. Puts us into, basically a hibernation state where it really slows down all of our vital signs, and slows down our processes, slows down the amount of waste that we're creating, and gets us to the point in which hopefully we're not using up nearly as much resources and creating as much crap. So in mild hypothermia, we're talking generally core temperatures between 90 and 95. And severe hypothermia, we're going to be talking temperatures less than 90 degrees Fahrenheit. So treatment depends on the degree of hypothermia that they're in. And our biggest treatment goal here is get them out of the cold environment, get them out of the wet clothing if the clothing is wet. So we're going to try to stabilize their temperature. We need to handle them very gently because remember, they've been still creating waste even though they may not have very fast pulse or respirations. That waste has continued to stagnate and pool in there, and the rougher we are with them, the greater chance that we can have all that waste get discharged into the circulation at once, causing them to have a severe acidosis. It hits the heart and it causes them to go into an arrest. So remove any wet clothing, remove any clothing or anything that's constricting so we can have optimal circulation. Cover them with blankets. Try to monitor their core temperature if you have that capability. Most ambulances anymore don't carry hypothermia thermometers. So in mild hypothermia, we may want to consider applying some heat packs. If we have the chemical heat packs, we've got to be careful not to burn them. Start IVs with warmed fluids if we have that capability. Do not throw these in the microwave and try to nuke a bag. It leads to hot spots in there. It's unreliable on the evenness of the heat, but actually can cause some harm and burns. So if you have a fluid warmer in your ambulance, great. Usually we'll warm it up to about 100, 110 degrees Fahrenheit. Give warmed, sweetened fluids orally only to patients who are fully alert and not nauseated. We're given some sweetened with a little bit of caloric intake there to help them have a little bit more of a fuel source to help warm their body. Do not give beverages that contain alcohol or caffeine to patients that are cold or patients who are hot. Okay? Those will cause some vasoconstriction, particularly in the cold patient, not to mention they're dehydrators. So those two substances will dehydrate you, and that's not something that either one of these patients need. Severe hypothermia, do not attempt to actively rewarm with hot packs or IV fluids. They need to be more passively warmed simply for the fact that we can, again, cause that discharge of all that waste product. If the patient is pulseless and has no signs of life, start CPR, apply your AED, understanding that AED may not work. Paramedics are taught that their medications probably won't work if the patient's so cold. So advanced airway as necessary, and then consider transport to a facility that can do cardiac bypass. So where they can do ECMO, where they pull the patient's blood out, they oxygenate it for them, and they put it back in. So the stages of hypothermia, you'll see a picture of this on 9:15 in your text. First, shivering response by your body to generate heat does not typically occur below body temperature of 90 degrees Fahrenheit. So if their body temperature is below 90, shivering is going to quit. Stage 2, apathy and decreased muscle function, so their fine motor function gets affected, and their gross motor function, so they might not be able to do things with their fingers, and it gets to the point at which they can't even walk. Stage 3, the decreased level of consciousness and responsiveness. Usually starts to get a kind of a glassy stare. Extremities are starting to freeze. Stage 4, they have decreased vital signs, so now the heart rate and the respirations have dropped. And stage 5 is death. Localized cold emergencies. So this is an example of frostbite. So it's a deep local frostbite. That tissues have been killed. They have necrosis there on the tips of their toes. So it's kind of a big problem. Frostbite, the intracellular fluid freezes. Remember, the majority of our body is water, and as water freezes, it turns to ice, and ice is crystals. So a lot of people, when they're getting numb in their fingers and toes, think, well, I'll rub them together in order to warm them up. You got to keep in mind, when you're rubbing them together, you're now rubbing little, basically shards of glass together. You're damaging and destroying tissues. So that's why we don't rub them. If you apply them up against something warm, that allows them to melt, but rubbing is going to cause the tissue damage. Superficial frostbite or frost nip. This is just really basically like a first degree or superficial burn. Frostbitten areas, we generally don't recommend thawing them pre-hospital-wise. The problem with this is a couple reasons. Number one, there's always the possibility that they're going to refreeze. If we have an issue with the ambulance, we run out of our heat source, what have you. The possibility of refreezing, it's going to make things worse. We don't massage or rub it. We can do, if we think that there's a good chance that it's going to be an excessive amount of time before this patient can get some rewarming, we may consider immersing things in lukewarm water, so right around 100, slightly, maybe a little warmer, 100 degrees Fahrenheit water, say 100 to 104, and then continuously monitoring that water to make sure it stays right around 100 to 104 degrees. That causes some very minor passive rewarming. The other big problem with this is it's very, very painful. As these things start to thaw, the patient's going to have lots and lots of pain. So possibly a little nitrous oxide might be helpful, or calling for paramedics to come and bring a bigger, badder painkiller. And our preference is to transport them to the hospital to be rewarmed. If anything, cover these areas. Put a dry, sterile dressings between fingers and toes, so we don't have skin on skin. When we have skin on skin, there's a chance that things are going to stick and cause more problems. Get them out of their cold stuff, minimize any additional effects, and get them transported. So dry, sterile dressings between fingers and toes, bandaged loosely. We're just trying to protect it. We're not doing we don't have to do bleeding control here usually. If there's any blisters, avoid breaking them. It's a good entry point for bacteria, and keep the part elevated. It'll help pull some of that fluid away. Don't forget to protect yourself from frostbite. So tight shoes and boots, those reduce circulation. Tight belts, neckties, whatnot, those all increase the risk of frostbite because it takes away some of that capillary circulation. Windy conditions greatly increase the rate of heat loss, and that's when we talk about wind chill. We have the wind chill chart in the text on 9:17, and it can show you how wind speeds of 5 to 40 in comparison to the thermometer reading, how cold it feels, or what the effect is on the patient. So, negative 40 degrees outside with a 25 mile an hour wind makes it feel like it's negative 104 out. So it becomes very cold very quickly with more and more wind. Cover all your exposed parts. Make sure you're bringing stuff along to help in case you have to go out on a long-term outside exposure. Caffeine and nicotine will increase your risk of frostbite because they cause vasoconstriction, and not to mention some dehydrations. Trench foot. Trench foot was very common actually in World Wars I and II, probably more so in one. Also called immersion foot. It's when a localized cold injury occurs when feet are immersed in cold water for prolonged periods. It causes severe pruning, basically what people call it, pruning, where you kind of get that wrinkled up skin and the painful, freezing, almost hard, wrinkled up skin, and actually leads to loss of circulation, can lead to frostbite very easily. So, prolonged periods of wet exposure, so wet boots and whatnot, can lead to trench foot. That continues on with your case study. So drowning. Drowning, primary respiratory impairment from submersion or immersion in a liquid medium. That liquid-air interface is present at the entrance of the victim's airway, and it prevents them from breathing in air. When we're talking about drownings, there's some terminology that has changed recently, and in fact, they even occasionally refer to near drowning in here in this presentation, which is not necessarily the most correct terminology. But near drowning is what we used to call it if the person survived, and it was a drowning if they died. The correct terminology now is a fatal versus a non-fatal drowning. So if they died from it, it's fatal. If they didn't die from it, it's a non-fatal drowning. So there is an animation on near drowning, or what we would now call the non-fatal drowning. So victims may live or die after this process, and whatever the outcome, they have been involved in a drowning incident. So this is where they're now kind of going to help you change your terminology and perspective. So demographic, it is the 7th leading cause of death in all age groups, 2nd leading cause of death in the ages of 1 through 14, and is the 5th leading cause of death for those under the age of 1. And it accounts for somewhere around 3,500 deaths annually in the United States. So no, it's not a widespread thing that we have to deal with. But when we have to deal with it, it's usually a very high stakes incident. The most common place for drowning occurs for children under the age of 1 is the bathtub, and in 1 to 5 is a swimming pool. And then adults and adolescents is most likely a natural body of water, so ponds, lakes, rivers, and oceans. Many times when it's adolescents or adults, there's also substance abuse involved or tomfoolery, whereas kids will get themselves into trouble. They get their head underwater and they can't get out from under. In the adolescent and adult populations, it's really the messing around, drinking, doing drugs, dived in, bonked my head, now I'm unconscious sort of thing. There are also potential underlying medical conditions. They may have had one of these that led them to drown. Sometimes one of these may arise actually as a result of the struggle of drowning. So hypoglycemia, seizure, syncope, MI, stroke. Additionally, they may have anxiety disorders, which leads them to panic, exhaustion, where they just can't do it anymore, hypothermia, and of course, like I mentioned, alcohol and drugs. Trauma. Basically, if you have a drowning incident and you have a patient that's not perfectly alert and oriented and able to describe everything to you, you should probably suspect a spinal injury because we just don't know. And in many cases, we may be talking about a diving incident. Now, in reality, spinal injury is fairly rare in drowning, but if it was a spinal injury that then led to a drowning, we just don't know. So that's why we're often erring on the side of caution. So if obvious signs of trauma, known mechanism, such as diving into shallow water head first or intoxication, consider spinal immobilization. You must not delay removal of the patient from the water to begin CPR. So don't dink around in the water doing spinal immobilization if the patient needs us to push on their chest. Get them out of the water. We'll deal with the spinal immobilization when we're ready to transport. Following submersion in a liquid medium, the patient first voluntarily holds their breath. Eventually they get to the point in which the reflex of swallowing water occurs. If that patient aspirates a small amount of water, usually they'll then have a laryngospasm and it'll constrict their airway, slams their vocal cords shut. And then carbon dioxide level increases in the blood, as does the oxygen level decrease in the blood if they can't bring in any new gases. Eventually the laryngospasm will relax. Active respiration of the gas cannot occur because they're underwater. They become hypoxic, hypercapnic, have some acidosis, can lead to cardiac arrest and an organ injury. And then the longer the patient's submerged, the poorer the prognosis. Other things to think about. Water contains pathogens. Do we have dirty water? If we got dirty water, do we have the potential for there to be pneumonias developing? Now, is that something that we can fix right now? It's not something that we can change right now. It is something that will have to be dealt with in the hospital, but it's something to at least keep in mind. Water temperature. Patients can be apneic for longer if they're hypothermic. Remember, not dead till they're warm and dead. So if they're hypothermic, the possibility of them coming back from this neurologically intact is pretty good. We've had patients that have had we've had patients who have been submerged for up to 45 minutes in cold water that have come back basically completely neurologically intact. So, and then patients with pre-existing medical conditions, they don't tolerate hypoxia quite as well. All right, you may or may not be, the patient may or may not be out of the water when you arrive on scene. If you are not trained in water rescue and you don't have the proper equipment, stay out of the water. It's something you definitely should train for. You should definitely get the experience, work with your local swimming pools and whatnot to do some water rescues with some lifeguards and kind of get a feel for it. But it is a very dangerous place to be. So if water rescue hasn't been dispatched, and there are numerous teams around western Iowa that specialize in water rescue, if they have not been dispatched, have them dispatched. It is our hope that the patient gets removed from the water as quickly as possible. Delaying resuscitation to perform spinal immobilization just further makes them hypoxic. So if it's possible that we can pull them out directly with a spine board, great, but it's not always possible. Sometimes the patient gets pulled out. We're not going to keep them in the water and say, no, don't pull them out until we get aboard. Get them out. We'll deal with the backboard later. And chest compressions cannot be effective until they're out of the water. If you're trying to push on their chest and they're still in the water, there's nothing to push against. So we're going to continue to work on their airway. There's probably going to be lots of suctioning that needs to be going on. We need to consider hypothermia. Of course, they're going to be hypoxic. Maybe there's traumatic injuries. I'm going to watch for any bleedings. Assess the scene for any hazards. Why did this happen? Make sure that the water isn't electrified, and that's why they had an incident. And ensure the safety of everyone else involved. If we can, determine what circumstances led to them being submerged. Somebody probably saw it if they called. Otherwise, how did we get notified that this person was underwater? So what was going on? Were they drinking? Do they have medical problems? Were they horsing around? Did they fall? Did they get hit in the head? Did they come up? Did they stay down? So on and so forth. Determine whether spinal mobilization is appropriate, and develop your general impression. If you don't have a pulse, of course, start CPR, get ready to do the AED. Make sure to dry the patient before applying AED pads. Remember, if you just slosh this sopping wet patient out of the water and you're kneeling in a big puddle of water next to them while you hit the button on the AED, be ready for a shocking experience. The most likely cause of cardiac arrest is hypoxia. So again, like I said, suctioning is going to be one of those things that we're going to be doing almost constantly with this person. And as we're pushing on their chest, we're probably going to get little bits of water out. So manually position their airway, place appropriate airway adjuncts, ventilate as necessary. Check for and control any external bleeding. If we can monitor their SAT, great. If they have cardiac arrest, that won't be an option. But perform a rapid trauma exam for those that are unresponsive or decreased level of consciousness, and monitor their vital signs, get a history. Do a focused exam for those that are conscious and oriented. So get information from them, what they feel is their major issues and their problems. Perform the head-to-toe on those that have a decreased level of consciousness who can't give us the full scoop of what's going on. Be alert for hypothermia. Reassess the patient's vital signs every 5 minutes on critical patients and every 15 on non-critical patients. Check the effectiveness of the interventions and record any findings in the PCR. A couple of things to consider with our drowning patient. Heat loss occurs 30 times faster in water than it does in dry air. So patients can become very quickly hypothermic, even in water as warm as 70 degrees Fahrenheit. And do you know seasonal temperatures of your local waters? Most of us probably can guess what our local air temperatures are on a seasonal basis. However, most of us probably aren't completely sure what our local water temperatures are. So it may be something that you should discuss with some of the recreational places, whether you have lakes and whatnot in your community that you serve, that you should maybe contact them and say, hey, what is the average July temperature of the water in our lake? Occasionally we also have diving emergencies. While it's not a very common thing here in the Midwest, we do have a lot of people who will travel, and traveling can lead to patients actually coming back home with some of these emergencies, particularly when they were diving and then got in an airplane. That compounds the problem. So diving emergencies occur due to the pressures exerted on the body in deeper waters, particularly when the diver breathes from compressed air from the SCBA. I'm sorry, from the scuba, not SCBA. The difference is the underwater part. So from the scuba. So underwater, the depth and the pressure are directly related. The deeper you go, the more pressure or weight that is exerted on you and the gases that you breathe. Dysbarism is a medical condition resulting from changes in the pressure. So we may have lots of nitrogen in our body that really doesn't do much of it, doesn't cause many problems because it's readily able to be disposed of when we're at our normal sea level, or normal environmental level, I should say. But when we have this 79% nitrogen in our blood, we go down under, these nitrogen bubbles get compressed and made very small, and then they kind of creep into other tissues that they normally wouldn't get into because they're now really small bubbles. And then we come back to the surface, then those bubbles re-expand, now being trapped in those areas they normally don't go. And so that causes some issues with typically nitrogen, but other gases as well, being now trapped, causing various medical conditions. So water exerts much more pressure than does air. So a couple of physics points here. We have Boyle's law. Boyle's law says the volume of a gas is inversely proportional to its pressure. Dalton's law says that the total pressure of a gaseous mixture is equal to the sum of the partial pressures of each individual gases in the mixture. So we hear partial pressures again. So partial pressures is when we have 79% nitrogen, 21% oxygen, you have to take the pressure of the oxygen and the pressure of the nitrogen into account. It's not just the pressure of air. It's everything that's within that gas sample. With the Boyle's law, by saying that, it says as a gas increases, its volume decreases. As the pressure of gas on a gas increases, its volume decreases. So the more we put pressure on the gas, the more tightly packed it gets. We also have Henry's law. Henry's law says the solubility of a gas in a liquid at a particular temperature is proportionate to the pressure of the gas above the liquid. So if we have more gas hanging out above the level of the liquid, we have higher levels of it, the easier it is to compress it into a certain liquid at higher temperatures. And then we also have Charles's law, which says all gases will expand equally when heated. So with Henry's law, basically what we're saying is when the diver descends underwater, the gases within his body are compressed and they dissolve into the blood and the tissues. And during ascent, when they come back up, those same gases, mostly nitrogen, and oxygen is mostly been used for metabolism, then start to exit the tissues, and they start to then cause problems within whatever tissues that they are in. So basically think of opening a can of soda, that pressurized gas dissolved in the soda. They're starting to cause all these excess bubbles. And then with Charles's law, we can look at that as being these gases will expand as the water temperature increases. The warmer the water we are in, so if we're in cold water down way deep, we come up into warmer water, they expand faster. Some general assessment and management. The time of the onset of signs and symptoms. That's something we're going to want to pay attention to. We want to know, how quick does this come on and how quickly is it progressing. The type of breathing equipment used, including what kind of tanks. So while knowing specifically about the tanks may not, and the gas that was in them may not mean a lot to us, it most likely will mean a lot to those people, the specialists that are being consulted when they're treating this dive victim. The depth of the dive. The deeper you go, if you go more than 33 feet, you're adding more and more. Every 33 feet you go, you're adding another atmosphere on top of you. So it gets worse and worse and worse the deeper you go. So, the number of dives. So it was this repetitive over several days. They were down. Greater chance that they got stuff stuck in there. Duration of each dive. How long were you down? Whether aircraft was used, because now if we were, 200 feet below sea level, which is probably excessive, we'll say 100 feet below sea level, And then all of a sudden, the next thing we did, we got out of the water, we drove directly to the airport, got in the airplane, drove to Denver. That really takes us from one extreme to the other. And was the cabin pressurized or unpressurized? So in most cases, if we're talking commercial airline, we're talking pressurized. So the rate of ascent, how quickly did they come up? What sort of experience did they have as a diver? Obviously, the more experienced divers know better ways to combat these issues. Any previous decompression illnesses. So if you've gotten sick while diving before. Medications that they may be on, any alcohol or drug use, of course. So barotrauma. When we're talking about barotrauma, we're talking about air pressure in a hollow space rises too high or drops too low. So during a descent dive, barotrauma is called the squeeze. When the pressure within the sinuses can't be equalized, and it can cause an injury to occur. So basically, air is trapped, you're going down, it's trying to change the size, and bam, it causes a significant pain. Could include things as pain in the ears or the sinuses. They may have some discharge of clear fluids or blood from the nose or the ears. You may cause some dizziness, some tinnitus or ringing in the ears, or some hearing loss. Usually, descent barotrauma is fairly minor, self-limiting in nature. Patients with upper respiratory infection, they can get some excessive congestions and whatnot, but for the most part, fairly self-limiting and not life-threatening. We can have some decompression sicknesses. So this is during the ascent, so we're going back up. The barotrauma occurred on the way down. So this is also called the bends, and nitrogen gas bubbles are produced. They accumulate in the blood and the tissues as a result of a rapid ascent during the dive. They already were there, they just didn't have an opportunity to get out of there because you came up too quick. So with a controlled ascent, a staged ascent, the diver will come up a little bit and then they pause. And that allows the pressure to kind of equal out, things kind of shift where they need to go, back and forth, and then they'll come up a little bit more and they pause. Allows some equilibrium. So it gives enough time for that air or those gases to move out of where they shouldn't be. Sometimes it can be very extreme. It can act like an air embolism in the bloodstream. So basically, like there's a big bubble of air stuck in your blood, traveling around. It stretches out those blood vessels, stretches the nerves, causes some pretty severe pain. Normally it's within the joints because that's where air gets trapped very commonly. That's the reason why when you pop your knuckles, they pop. There's a little air stuck in the joint. Also can be within the abdomen because remember, a lot of your hollow organs in there, and your hollow organs, that air is expanding. So we can have type 1 or type 2 decompression sicknesses where the nitrogen bubbles within the nervous, respiratory, and circulatory systems in type 2 become kind of a significant issue. So type 1, I mean, this is still called the bends, but so we're talking really more of a capillary issue and a skin tissue problem where, you know, that's probably an itchy, burny sort of thing, but for the most part it is, you know, or maybe even into the joints a bit, but for the most part it's more of an irritation than anything. Whereas with the type 2, we're really now getting involved the major organ systems that include things, back pain, weakness, paralysis, incontinence, headaches, visual disturbances, dizziness, nausea, vomiting, tinnitus, chest pain, particularly upon inhalation, non-productive cough, respiratory distress, signs of shock, pulmonary edema, seizures, peripheral edema, so lots of different things. Potentially these people are going to require recompression, and to recompress patients they have to go to a hyperbaric chamber, and in most cases in the Omaha Metro that's going to mean going to the Nebraska Medical Center in the Clarkson Tower, where they get put in this tube, the hyperbaric chamber, and basically they are recompressed. They're put in this very strong tube that they will then crank up the pressure on the inside there. They'll slowly crank the pressure up. They'll take that patient to the same amount of pressure that they were at when they were at their deepest points in their dive, and then they just slowly bring them back up. Or in reality, they slowly bring the pressure back down, but it's essentially simulating ascending back to the surface again. So they get placed in the hyperbaric chamber. They're subjected to pressurized oxygen, and it's higher levels of oxygen there helps force a lot of that extra nitrogen out, because the body's not used to having, the body's used to having all this nitrogen in place. The oxygen molecules get in there and they kick it out. The body can use the oxygen; it doesn't really use the nitrogen, so it's much easier and safer on them. Causes that nitrogen to redissolve, move out, get back into the bloodstream so it can be exhaled. And again, like I said, they slowly bring you up from under that heavy pressure. What are we going to do with them? We are going to manage the same basic supportive needs that anybody has. The ABCs are our main concern. High flow oxygen. This is kind of our quote-unquote attempt at trying to replace some of that nitrogen. If we flood the system with some oxygen, in theory, hopefully we can kick a little extra nitrogen out. We're going to transport them in a supine position. Any air bubbles that form, we don't want to go rushing up to their brain, so we transport them supine. Some places might even talk about transporting them in a Trendelenburg position where their feet are actually a little higher. So any bubbles that would be formed in the bloodstream would actually travel towards their feet instead of towards their brain. We may also provide them with some IV fluids. And if air transport's to be used, the patient must not be exposed to a decreased barometric pressure. So that means that they're going to have to fly at a low level. So it's because changing of those bubbles again, the higher you go, the bigger the bubbles. And they also recommend notifying the emergency department as soon as possible so they can notify the Divers Alert Network, or the DAN. Diver Alert Network, they have a lot of guidelines that they can assist with patients who have had diving incidents, as well as they have some other recommendations. They recommend divers spend at least 12 hours on the surface before jumping in a commercial aircraft, and an extended period of time beyond 12 hours should be spent on the surface level following daily multiple dives for several days. So they're just trying to say, let's get as many of the air bubbles out of you as possible before we submit you to lower pressures. They can build an arterial gas embolism. This may be a result of a decompression sickness, but if the ascent occurs too rapidly, or if the diver holds their breath during ascent, those nitrogen bubbles will form in an artery. This can be fatal. It can cause a stroke, can cause a heart attack. It's basically going to look very much like either one of those things. So we may have respiratory distress, altered mental status, dizziness, chest pain, severe pain in the muscles or joints, which would not be common for a stroke or a heart attack. Visual disturbances, hearing loss, nausea, vomiting, paralysis, numbness, lack of coordination. All of these are on 921.22. Frothy, bloody sputum, which would not be common, of course, unless you were talking to a patient with CHF. Edema around the neck, memory loss, stroke, coma, cardiopulmonary arrest. So really the treatment for that is, again, very supportive measures. So it's going to be watching our patient just for ABCs. So we may also have a nitrogen narcosis, in which they actually they often call it the rapture of the deep. It causes the patient to go into basically a little stupor because there's too much nitrogen now taking effect on the brain. They may act intoxicated. They may take risks that they normally wouldn't. This could potentially really have a problem with doing dangerous things during their dive. So they often will refer to the martini effect, because they say it feels like you've had one martini for every 33 feet in depth that you've descended. So sometimes they stay underwater way too long. Again, very supportive. So diving emergencies can occur anywhere that there's water deep enough, such as inland stone quarries, but honestly not very common in our area. So patients who died and then flew certainly can have complications after those. Thorough histories are critical. Altitude illnesses, just like getting too far underwater can cause problems, being too far over the water can cause problems as well. So being at excessive altitudes. So we have a decreased atmospheric pressure, everybody's aware of that, and when you ascend too high in these altitudes and your body doesn't have time to adjust or acclimate, then your body, number one, it becomes hypoxic because there's less oxygen to be had at those higher altitudes. And then the pressures are so much different that what you're used to, having X amount of pressure to keep some of your fluids from creeping into your alveoli, you now have to adjust a little bit to the new lesser pressure that makes it much more difficult for that plasma to keep from seeping. So basically one of our goals here is to deal with the hypoxia and then quickly get them down to a lower altitude where their body can adjust better. A couple of the types of illness that we might talk about, and again this has a lot to do with partial pressures, but acute mountain sickness. Person ascends to an altitude of 2,000 meters or 6,600 feet too rapidly. So this is well over a mile above sea level. So they go up way too quick. They can develop this acute mountain sickness that includes things such as lightheadedness, mild shortness of breath, weakness, headache, nausea, and vomiting, which in most cases people wouldn't think twice about. But by history, if you go and you start asking more questions about what's happened, might think, well, they might have thought initially they just had the flu, but come to find out it's due to too quick of a change in pressure. This can progress on to severe signs and symptoms of, extreme weakness, vomiting, shortness of breath, changes in mental status. Again, we're going to concentrate on maintaining ABCs, and getting them out of that high level. So if the ascent is discontinued after the initial symptoms, the patient generally will improve pretty well within 2 days as their body kind of adjusts. Make arrangements to get the patient to the lower altitude as quick as possible. And if necessary, consider a little bit of fluids. Some places, paramedics might also give something for nausea and vomiting. So we have HAPE, high altitude pulmonary edema. This is a pretty serious situation. This is non-cardiogenic pulmonary edema. It occurs at an altitude of greater than 2,500 meters or 8,200 feet above sea level. The patient then starts to develop some tachycardia, shortness of breath, rales and coughing, weakness, coma, and potentially even death. The reasoning for this is, like I said, your body is used to a certain amount of pressure being within your lungs. When you breathe the breath of air in, you breathe the breath of air out. And knowing that all these equilibriums and all these pressures that your body's used to, it can keep your plasma from seeping in. Well, when you change those pressures, then it makes the probability of kind of tripping the fail-safe, and some of the fluids then start to get a little leaky because they're not used to that. And so that's where the pulmonary edema comes from. The same sort of thing can occur in your brain, whereas it increases the amount of fluid in your brain or around your brain, and it causes increases in intracranial pressure. So these people may look like head injury patients. So they'll have lack of coordination, decreases the level of consciousness, seizures, headaches, vomiting, comas. It can potentially lead to death. So both of these are fairly ugly problems to have to deal with. We're going to treat them usually with some high flow O2. Potentially need to ventilate these people, but the person with the pulmonary edema may even benefit a little bit from some CPAP. The person with the high altitude cerebral edema, maybe even some slight hyperventilation. But the high flow O2 will help do a little constriction of blood vessels and hopefully drop some of that pressure as well. You would want to be extremely cautious with any IV fluid you would give these people. So. All right, so ascension in high altitudes must occur gradually. So you talk to medics that work in the Rocky Mountains, and they'll have all kinds of stories to tell you. People who thought, hey, you know, I've had no training, but I can go climb that mountain, and whammo, end up with one of the three illnesses. So acclimation is the key. So acclimatizing oneself to their atmosphere is critical and crucial, and then limiting physical exertion until the body kind of resets all of its pressure settings until after you've had a little bit of time and your body now is more comfortable with that. It's going to lead you to have much fewer problems. So usually takes around a week to become completely acclimatized. And most people are able to function pretty normally after a couple of days. The final thing we're going to touch on in this chapter is lightning injuries. 30% of lightning strikes die. 74% of survivors have a permanent disability. You know, could be nervous system, could be hearing, something along those lines. A couple of things that need to be kept in mind when discussing electricity and lightning. Current and voltage. Voltage is the measurement of energy within the electrical circuit at any given point. And current is the flow of electric charge through a conductive material. Current is referenced by a unit of measure called amperes, or often called amps. So an amps is usually the major problem. Amps, the higher the amps, the bigger the problem. So our standard household circuit is 120 volts with a current of 20 amps. The voltage and current of lightning is in excess of 1,000,000 volts and 200,000 amps. So think of a comparison to standard household electricity, that 110 volts and 100 amps of current. Temperatures generated by lightning can exceed 60,000 degrees Fahrenheit at the point of contact. So you can have a direct strike in which the lightning hits the victim first and uses it as its route to get to the ground. You can have contact strike in which the lightning hits something else and the patient is affected by that strike as well. So basically they get kind of a secondhand hit from it. Side flash strike, lightning hits an object and then jumps to the victim who's located nearby. Or you can also have the ground current strike in which the ground has been energized and the person is standing on the ground. They take up some of that electricity. Usually when we're talking about lightning strikes, we're also talking about musculoskeletal issues, because remember your muscles all run off of basic electricity, and so excessive amounts of electricity flowing through your muscles can cause them to have damage, not to mention cause some problems with fractures of bones and whatnot. This is a very, very common occurrence when we have lightning strike incidents. It's called ferning. You can see the kind of burn pattern on him. It looks like feathering or fern fronds across his right shoulder here and his upper chest. That's a very, very common pattern that you see with a lightning strike. So now he probably also has maybe an entrance and an exit wound. It's hard to say, you know, where exactly those would be. Most of the time the exit would be at the ground where he grounded out. So if you're responding to a lightning strike, of course, remember that we need to ensure the scene's safe. If it's lightning any time in the last 20, 30 minutes, it's still a pretty good chance that it could lightning very closely again. Lightning strikes are going to affect all the body systems. Remember, it's going to run through the vessels, it's going to affect the muscles and potentially crack some bones. It affects the cardiac system because the cardiac system runs off of electricity. So we have multiple potential problems here. And the energy produced by a lightning strike is going to burn everything in its path. It can also completely disrupt the electrical systems everywhere. So management is generally very supportive. Treatment of burns, treatment of the musculoskeletal injuries, cardiac arrest. Of course, we're going to treat as most of our, just like any other cardiac arrest. So some signs or symptoms of lightning strikes might include altered mental status, amnesia, weakness, pain, tingling and numbness, paralysis, dizziness, fixed pupils, seizures, burns, particularly that ferning pattern, joint dislocations, fractures, tinnitus, ruptured eardrums, failure or hearing loss, respiratory failure, cardiopulmonary arrest. All right. People can become victims of the environment in many different ways. Injuries can be very minor, but they can also be very life-threatening, particularly for ill people and the especially old and the especially young. We need to respect our environment and be prepared ourselves for the conditions in which we may be exposed. We are not immune to these illnesses or injuries as well. We could very easily become victims of our environment. Always take your precautionary measures. Our goal is to identify the potential causes and then to treat them with the standard supportive means that we would for ABCs.